my healthcare brothers and sisters. I hope that you're having a wonderful day. Today we are continuing on with our cardiovascular assessment and electrocardiogram like a boss series, and we're going to start looking at our potentially lethal rhythms, also known as our ventricular rhythms. So to begin, we're going to be looking at our first potentially lethal rhythm, ventricular tachycardia. So what is that? It has a rate of 100 to 220 beats per minute. The rhythm will be regular. P waves are going to be non-apparent, and because they're non-apparent, that means there's no PR interval. However, those QRS intervals are getting worse, like those idioventricular rhythms are getting so much worse. They're wide, they're ugly, they're disgusting, they're greater than 0.12 seconds. The definition for ventricular tachycardia is 3 or more PVCs in a row that is either non-sustained, less than 30 seconds, or sustained more than 30 seconds. Adequate blood pressure is difficult to sustain due to that rapid firing and can lead to ventricular fibrillation if it's not treated. So causes for ventricular tachycardia include hypoxemia, digitalis toxicity, myocardial infarction, ischemic heart disease, mitral valve prolapse, and cardiomyopathy. So interventions are really dependent on whether the patient has a pulse or doesn't have a pulse. If the patient is pulseless, we're going to use the ventricular fibrillation algorithm in regards to treatment. However, if they have a pulse and they're stable, we're going to provide oxygen if oxygenation is inadequate. Synchronized cardioversion can be another potential intervention, as well as adenosine for regular and monomorphic VTAC. Antiarrhythmics such as Amiodarone may be used, as well as Lidocaine. So synchronized cardioversion is so much fun, not for the patient, but for you. So it involves the delivery of a low energy shock, which is timed or synchronized to be delivered at a specific point in the QRS complex to avoid causing ventricular fibrillation. So how do we do this procedure? We're going to obtain a 12-lead ECG if the patient is stable. We are not going to delay cardioversion if the patient is unstable because we're waiting on a 12-lead ECG. So if they're stable, get the 12-lead ECG. We're going to prepare proper sedation since cardioversion is extremely painful, and have emergency equipment nearby in case of complications. We want to place the defibrillator pads on the patient and set the monitor to synchronized or sync mode. Sync mode will deliver a concurrent energy with each QRS. We want to engage the sync mode before each attempt, and we want to look for those sync markers that are going to be above each R wave. So what do our voltage dosages look like? So the initial recommended voltage doses for narrow regular is between 50 to 100 joules for our SVT or atrial flutter. Our narrow irregular rhythms are going to be between 120 to 200 joules if we're using a biphasic defibrillator, or 200 joules for a monophasic defibrillator. We see this most with our atrial fibrillations. Wide regular is going to be 100 joules used for our monomorphic ventricular tachycardias, and our wide irregular rhythms are just going to be using our defibrillation doses. We're not going to be looking at synchronized cardioversions. We're just going to be defibrillating those shockable rhythms. We want to clear our personnel from the patient prior to giving the shock, and we're going to press the charge button. We're going to announce clear the patient. Once we know that the people that are helping us with this patient are clear, they're not touching the patient, they're not touching the bed, we don't want to shock anybody who doesn't need to be shocked, we're going to press the shock button. After we press that shock button, we're going to reassess our patient's rhythm on the monitor and make a determination if additional doses are needed. So let's talk about adenosine. This is such a fun drug, not for the patient, but it's fun to watch. It's the first drug of choice for stable narrow complex supraventricular tachycardias, and it may also be considered for unstable narrow complex tachycardias while we're waiting for that cardioversion to occur. It does not convert atrial fibrillation, atrial flutter, or ventricular tachycardia. So that's something important to note, and we don't use that for those things. So adenosine dosing. We want to place the patient in a mild reverse Trendelenburg position. So they're just going to be a little slightly up. The initial bolus is going to be 6 milligrams given rapidly over 1 to 3 seconds. You want to push this quick. That's going to be followed by a normal saline flush of 20 mLs, and we want to elevate the extremity that we have delivered the medication through, so that way it gets to the heart quicker. Anytime we have these medications, we want to elevate the extremity afterwards, get it to where it needs to go quicker. We can provide a second dose of 12 milligrams IV push over 1 to 2 minutes if needed. I have seen it given more than once. I have seen it given twice. If it doesn't work after 2 times, it's probably not going to work. So how do we give adenosine? So we're going to record the rhythm prior to administration as the reason why we're giving this medication. We're going to draw the adenosine up based on the dose that we're giving, and we also want to make sure that we have 2 separate syringes of normal saline, both 10 mLs. We're going to connect a port to the IV, and we're going to attach both syringes to that port. We're first going to push the IV adenosine as quickly as possible, and then we're going to remove that port dial to push the normal saline as rapidly as possible while maintaining pressure on the adenosine syringe. So some important considerations that you want to consider when giving adenosine is it's not to be used in poisoned, drug-induced tachycardias or 2nd and 3rd degree blocks. This will actually make it worse. Side effects may include flushing, chest tightness, and a brief period of asystole or bradycardia. Of course, we're going to see that brief period. This is what adenosine does, right? Dosing may change based on medications or central venous access following the provider's order. And lastly, if administered for a polymorphic wide complex tachycardia, we have to be on the lookout for hypotension because this can actually make it worse. So let's talk about amiodarone. Amiodarone can cause toxicity, so we only really use this in patients with life-threatening arrhythmias with administration and sufficient monitoring. So when do we give this? We give this for ventricular fibrillation, ventricular tachycardia that has been unresponsive to cardioversion, CPR patients, as well as a vasopressor. So hemodynamically unstable ventricular tachycardia patients may also receive this as well. Dosing, you want to have a maximum dosing of 2.2 grams IV over a 24-hour period. So with our rapid infusions, 150 milligrams IV given over 10 minutes may be repeated every 10 minutes PRN depending on what the rhythm shows. Slow infusions of 360 milligrams IV over 6 hours can be used, as well as a maintenance infusion of 540 milligrams IV over an 18-hour period may be used. So amiodarone considerations, rapid infusions can actually cause hypotension. So that's why we have to have a sufficient monitoring. Multiple dosing over that 2.2 grams in 24 hours may actually increase that severe hypotension, which is why we really want to limit it. We do not want to administer with other drugs that can prolong the QT interval because this drug will also prolong it. And the half-life of this will last up to 40 days, which is why we want to be making sure that we monitor them appropriately when we're administering amiodarone. So when looking at lidocaine, lidocaine is considered immediately after the return of spontaneous circulation, such as ROSC with our ventricular fibrillation, pulseless ventricular tachycardia, cardiac arrest patients, and it's also an alternative to amiodarone in cardiac arrest for ventricular fibrillation, ventricular tachycardia, and our stable monomorphic ventricular tachycardias. So when we're looking at dosing for cardiac arrest, the initial dose will be between 1 to 1.5 milligrams per kilogram IV or IO. Refractory ventricular fibrillation, additional doses can be given at 0.5 to 0.75 milligrams per kilogram IV push every 5 to 10 minutes with a maximum dosing of no more than 3 doses or a total of 3 milligrams per kilogram. When we're looking at stable ventricular tachycardia, wide complex tachycardias, we can give 0.5 to 0.75 milligrams per kilogram up to 1 to 1.5 milligrams per kilogram. And repeat doses, of course, can be 0.5 to 0.75 milligrams per kilogram every 5 to 10 minutes, following that same maximum dosing of 3 milligrams per kilogram, no more than 3 doses. If we have to give this as maintenance dosing, we're usually looking at 1 to 4 milligrams per minute or 30 to 50 micrograms per kilogram per minute. So other considerations when it comes to lidocaine that we want to consider is prophylactic use in acute myocardial infarction is contraindicated. We don't want to give this to these patients. Reduced dosing for the maintenance dose is considered when we have impaired liver function or left ventricular dysfunction, as well as we want to discontinue infusions if toxicity is present and there are signs and symptoms. I hope that this video was helpful in elevating your cardiac knowledge and helping you pass those exams like a boss. Make sure that you check out my website at www.nursecheung.com, where you can get copies of these resources, the PowerPoints, as well as test questions that I will be including with each one of these videos within the series. If you have any questions, please feel free to leave them down below. I love answering your questions, and make sure you follow me on my social media. I'm on Facebook, Instagram, Twitter, as well as here on YouTube. Make sure you subscribe and make sure you turn on that notification bell. Until next time, I hope that you're having a wonderful day, and I can't wait to see you all again soon. Bye!